Nilu's a hematologist and a clinician from Royal Brisbane Hospital who focuses on CAR therapies, but you haven't got infections as an interest there, which has surprised me because I didn't know there was anything else that was interesting. So there you go. Maybe English Premier League football is quite interesting. But Nilu's working very closely with us on infectious diseases. We're very lucky to have her on the team, and is really, along with Andrea Hendon, pioneering work in CAR T therapies, which we seem to be doing more and more of as well. And they're coming with a whole lot of new confusing infections and syndromes that look like infections but aren't. So I'll click on there.
Thanks everyone for coming today. I want to start off by thanking the organisers for asking me to speak today. I was just actually joking with Adam before that as a haematologist, I tend to break people with my therapy, and then I call my friendly infectious disease colleagues to help me fix them. So this is one of the new ways we've figured out, hopefully to fix people, but we also seem to break them, and that's CAR T therapy. So in terms of contents, this is sort of what I'm hoping to cover a little bit. Some of this is all knowledge for most of you guys, but we'll just cover it quickly. So CAR T therapy, so what does it actually stand for? So chimeric antigen receptor T cell is what it stands for. It's a living drug and it's tailor-made for each individual patient. And the CAR T cells are genetically engineered to give T cells the ability to attack specific cancer cells. So this is just a very basic image of a second generation CAR T and how it works. So you can see the scFv variant is what really allows antigen recognition, and in the most cases that's CD19 or BCMA. Once it's recognized, the antigen, it'll really trigger this downstream mechanism, triggering the co-stimulatory domain and then T cell mediated killing. So how and why was this therapy approved? So these were the 3 pivotal studies that led to approval of CD19 CAR T therapy for diffuse large B-cell lymphoma by the FDA and TGA. Usually I say we're about 10 years behind the US, but this is one of the instances where we actually really got on board quite quickly. So in diffuse large B-cell lymphoma, we know in the relapse refractory setting, patients have really dismal outcomes. We're talking not many curative options at all. So when this came into the space, not only were people getting overall responses, but durable responses. And that's really what led to its approval. So in brief, how does a pathway work for our standard care CAR T? So once they've been approved, we will apheresis their lymphocytes, then ship them to a GMP facility where the T cells are selected out. There's a lentiviral transduction step. Then there's expansion of the CAR T cells. They'll go through a quality kind of aspect there. And then once that's been passed, they're shipped back to the treatment center. We then give them lymphodepleting chemotherapy and then infuse the cells. So in Australia, we have 3 products that are now approved for commercial CAR T, and that's listed here with the various indications listed. But you have to have multi-relapse disease, so failed at least 2 prior lines of therapy. And in Queensland, you can only access it if you're under the age of 75. You need to have good organ function and a very good performance status of ECOG 0 to 1. So I always like to talk about a case. So this is one of our patients. She was in her early 70s. She'd had at least 3 lines of therapy and a stem cell transplant. Unfortunately had relapse lymphoma. You can see pretty bulky extranodal and nodal disease. So this was her pre-CAR T PET. And then at day 30, she got into a great CMR. So we're really, really happy. But mainly at 12 months, she stayed in CMR. And now she's about 2 years down the track, very healthy and happy. So for her, it was a life-changing treatment. So with all these very expensive therapies, I guess the questions we ask are, is it a durable response? Is this a cure? I think we're getting closer to answering those questions. So we're getting longer readouts from those initial trials. So this is a 5-year readout from the ZUMA-1 study. And it showed an estimated 5-year overall survival of 43% and a bit higher in patients who achieved a CR. So I think it's supporting the curative potential of CAR T therapy, particularly for patients that have refractory disease who don't really have any other curative options. So like with any new therapy, there are new toxicities we learn about. So the 2 main things when we talk about acute CAR T toxicity is CRS or cytokine release syndrome and ICANS, immune effector cell associated neurotoxicity syndrome. We really like our acronyms in hematology. And so both of these conditions happen within sort of the first 10 to 14 days. Again, the onset can vary depending on your CAR T product, your underlying disease status, and your performance status. Management for CRS really is tocilizumab driven, so it's an IL-6 inhibitor, and steroids. In ICANS, if you don't have CRS, it's usually steroid based. If we're looking at refractory ICANS, we tend to use anakinra as well. So I think we know that CAR T has been demonstrated to be effective and durable, but we know it has a profound and long-lasting immune deficits and dysfunction, as discussed sort of prior in these topics. But when it comes to these new therapies, we don't actually have a lot of information on non-relapse mortality, which I think is a really important part of any new therapy. So the German group went and tried to answer this question. They performed a very large meta-analysis, and they looked at all the clinical trials that led to the approval of the current 6 commercial CAR T products, plus their phase 1/2 trials and real-world studies. So that was about 5,000 patients that they looked at. And interestingly, over half the studies didn't report any measures of NRM, which is quite interesting. But in those that did, there were about 441 deaths, and of that, 210 were due to infection, so 48%, so it's pretty significant. Comparing that to CAR T toxicity-related death, which was actually 11%. So this diagram here is quite interesting. These are different types of indications for CAR T, so multiple myeloma, mantle cell lymphoma, large B-cell lymphoma, and indolent lymphoma. And for all of them, infection is the biggest cause of death. So the French group used their very large CAR T registry data and found very similar findings. So infection was the biggest cause of NRM, and it often was after day 28. So I think this shows us infection risk is really high with this patient population, but the why is quite complex. It's multifactorial, it's due to host and treatment-related factors. And I think this diagram really highlights the various components of it. So interestingly, the most common grade 3 toxicity we see after CAR T therapy is actually hematotoxicity. So this has left us to coin the term ICAT, or immune effector cell-associated hematotoxicity. The incidence is really high, it's often biphasic, and there's lots of different contributors. So if we look at the pre-CAR T infusion state, often it's patient-derived factors, so their bone marrow status, underlying disease burden, and their previous cytotoxic therapies they've had. In the early phase post-infusion, often we think the cytopenias are related to the lymphodepleting chemo they have, the CAR T construct that they get. But to me, I guess the most interesting part of the ICAT is this late ICAT phase, so after day 30, and that's really when people are coming back into hospital, having recurrent infections and ongoing transfusion need. And this is where there's really not a lot of understanding of why this happens. There's hypothesis that it's the CAR T having some sort of effect on the bone marrow stem cells, but again, it's not really clear. So the national sort of EBMT organization decided to grade ICAT and see how that would sort of clinically translate. So we have grades 1 to 4, early versus late. And what's really interesting is, more severe your ICAT grading, so grade 3 to 4 means you're going to get more severe infections. So we're talking grade 3 infections requiring hospitalizations and grade 4 life-threatening infections. And then this translates into a higher 1-year non-relapse mortality. So do we have any tools to predict who might develop severe ICAT? So we have this tool called the CAR Hematotox score. It's actually a really simple score you can calculate before the point of lymphodepletion. We just look at their full blood count, their CRP, and their ferritin. And it's really identified 3 distinct groups of neutrophil recovery. So there's quick recovery, intermittent recovery, and the aplastic group. And the aplastic group's really interesting. So they tend to have more severe protracted neutropenia, higher rates of severe infection, more ICU admissions, and a trend towards higher NRM as well. So how do we manage ICAT? So it's pretty sort of bare bones at the moment, really. Early use of G-CSF for neutropenia. Thrombocytopenia, I'd say it's more transfusion support, but if we can access TPO agonists, we will. Stem cell boost is really interesting. It tends to work really well, actually, but not many patients have autologous stem cells banked before we go to CAR T. So I think antimicrobial prophylaxis really is our backbone for most patients. But as we've heard today, everyone does prophylaxis differently. So this is sort of a snapshot of, I think, what most centers try and apply. So similar to hematopoietic stem cell transplant, the patterns of infection observed following CAR T infusion change over time. Most of our infections occur in the first 28 days, and it's usually bacterial infections in this sort of first time point. So neutropenia is the most common risk factor, and one of our trainees, Dr. Jess Pearce, will present a case later highlighting really the complexities of managing these patients and the infective complications. Viral infections tend to occur after day 30, and it's usually respiratory, and it's mild to moderate severity. During COVID, a lot of our patients actually unfortunately passed away. So that was a really big contributor of non-relapse mortality. Herpes virus reactivation, we tend to see later down the track, so in the 6 to 12 month mark. So most of our patients stay on antiviral for at least 12 months. Fungal infections are quite interesting. Overall, I think rare, but they're reported fairly sporadically at 1 to 5%. And again, the highest risk factors are neutropenia and prolonged steroid use, which unfortunately we have to use for our acute toxicities. In our local experience at the Royal, we've mainly seen Aspergillus, but we've had one case of severe Candida cruzi and one case of Fusarium. Oh, should I click those before? So what about rarer viral infections? So CMV viremia, as you know, in the allogeneic space is really important. There's been lots of great talks on it today. But in the post-CAR T setting, there actually is not a lot of evidence. It's not routinely measured, so the incidence varies. So Campuri and her group in the US tried to answer this question to a degree. She looked at 72 CMV seropositive patients and monitored their CMV weekly for 12 weeks. And interestingly found reactivation only in 27% and no evidence of end organ disease. But that she did find there were 2 groups that had a higher risk of reactivation, and this tend to happen 2 to 6 weeks post-infusion. So if you had a BCMA CAR, you were higher risk of reactivation, and if you had steroids, VCRS or ICANS. So their recommendation was probably don't need to screen everyone routinely, but maybe those that are considered high risk, and particularly in that 2 to 6 week mark. Now, HHV encephalitis has also been really topical recently. There have been several case reports published of patients suffering from this post-CAR T. I think the diagnosis is really challenging because there can be an overlap with ICANS. So it can be a really difficult area. So Josh Hill and his group really tried to look at this both in a retrospective and a prospective manner. In his prospective study, he looked at weekly HHV6 testing for 12 weeks and found reactivation was quite transient and low level. And overall, the encephalitis rates were 0.2%, so very rare. When he retrospectively looked at paired blood and CSF samples for 34 patients, there's only one possible HHV encephalitis. And again, the patient's symptoms improved without treatment. So there's probably not enough evidence to suggest routine monitoring is required, but we should be guided by clinical suspicion. So then we go on to sort of talking about the on-target off-tumor effects of CAR T, which we know there are many, but mainly the prolonged B-cell and plasma cell depletion leading to hypergammaglobulinemia and depletion of specific antibodies. So when we look at CD19 CAR, we know it tends to mainly affect your naive B-cells and your memory B-cells. So your IgG titers might drop a little bit, but your diversity of your antibodies is maintained. When we look at BCMA CAR, however, we know that BCMA is expressed in our long-lived plasma cells as well as the normal plasma cells. So there's a much greater drop in the diversity. So there's a lot of growing evidence that there's poor maintenance of pathogen-specific IgG levels in those that have had a BCMA CAR. So how do we tackle this sort of on-target off-tumor effect of CAR T? One strategy would be IVIG replacement, but we know IgG levels themselves are not an adequate biomarker of humoral immunodeficiency. So Josh Hill and his group again have created this proposal for consideration of replacement, and it's similar to what we follow clinically. So in the BCMA space, if there's a significant drop, we know there's a significant drop in diversity, we would recommend replacement if your IgG levels are under 4. And similarly in the pediatric population, we know that they've got a limited pre-established plasma cell repertoire, so we would recommend replacement for them as well. But as you can see, we probably need more sophisticated tools for risk stratification and decision-making. So just wanted to probably touch on this. There's a lot of room for future research. And I think in the last 2 to 3 years, CAR T has exploded onto the scene, and not just in hematology now. We're looking at it in solid organ malignancy. These are just some of the targets for CAR T. And I think even more exciting, maybe terrifying, is that we're looking at it in the autoimmune space. So this young girl here had severe refractory lupus, and she was treated with a CD19 CAR and, deemed possibly cured from her disease. And, I love my dog, so if she got refractory lymphoma, I might take her to the US and enroll her in a CAR T trial. So there really is no limit. But I think this means, management of toxicity will become quite difficult and will need to be probably very nuanced. Managing someone with heavily pretreated lymphoma is going to be different to managing someone with lupus or myasthenia gravis. So I think we'll need collaborative approaches moving forward. And I think non-relapse mortality is something that's really important to factor into with these new therapies. If we're using a potential curative therapy, we want patients to live long enough to actually benefit from that therapy and not pass away from infection. And then discerning sepsis infection from CRS and ICANN, there's also like a very, I think, fruitful area of research. We need more tangible ways to differentiate between them. Currently, we just have very crude measurements of CRP, blood cultures. But one of the studies we're taking part in at the Royal is the T2MR study, where they're looking at emerging diagnostic techniques for the diagnosis of severe infections in neutropenic patients. So I think things like that are really exciting and awesome to be a part of, because that's probably what's going to help us in the future with these new immunotherapies. Thank you. It really does take a village, so I just wanted to thank all my team at the Royal and the patients and their families.
Thanks, Neely. That was great. Well, again, we'll push on for time's sake. Great to get a plug for the T2MR study, and I'll crack on with the next speaker.